already in the room? Okay, great. So I will let the first presenter take over. Just a couple of ground rules for the room. If everyone can check that their phone's on silent. Ground rules for online, make sure you're on mute while the presenters are talking. Hamish will keep an eye on any questions in the chat. So Hamish is your online chair. Give us a wave, Hamish. And I'm Rosie, I'm your 3D chair. So I will introduce Gary, who's going to give us the first presentation. Yeah, this is your mic.
Excellent, thank you very much. My name is, can you all hear me? Take that as a yes, thank you, Hamish. Thank you very much for having me. My name is Gary Kainth. I am a social worker and a research associate in the Institute, and I'm going to talk about our RCT, the Best Services Trial, and specifically the process evaluation within that. My colleague Fiona Turner is also here, and she'll be on hand to sort of answer questions at the end. Fiona's a qualitative expert. I'll just launch straight into it. So BeST, with a question mark, is a large RCT taking place in Glasgow and London, and it's funded by the NIHR and the NSPCC. It's just occurred to me, people in the room can't see the slides. Yeah.
Sorry, yeah, please can you share your screen?
Oh, sorry, yeah. I'm just wondering about that.
Thank you.
Can you see that okay? Oh, there we go. Excellent. Sorry about that. So BeST is a large RCT. It's taking place in Glasgow and London. It's funded by the NIHR and the NSPCC. It's for families with kids under the age of 5 who are in care for abuse and neglect, who are the vast majority of children that come into care. And it's comparing the effects of two different approaches to working with families: NIM, the New Orleans intervention method, versus services as usual. I will apologise in advance for all the acronyms that you're about to see, but I'll try to minimise them. Our question is, what is the best way to improve the mental health and placement stability, i.e. keeping children in the same placement or minimising the number of times they have to move placement, of preschool children who have come into foster care because of abuse and neglect? And we're trying to work out, is an infant mental health model or a social work model the best way to achieve this? So very, very quickly, in terms of the RCT, and this isn't what I want to focus on, but this gives you an idea of some of our outcome measures. We measure the mental health and well-being of the children using all those measures, the SDQ, the Strengths and Difficulties Questionnaire being our primary outcome measure, relationship between children and their primary caregiver. The second there is the This Is My Baby questionnaire. Time taken to reach permanent placement. So how long does it take a child from the point they come into care and to the point where they are in a permanent long-term placement? And the bit that everybody wants to know, what is the long-term cost effectiveness of services, including current service use and model future service use. There's absolutely no point in an intervention being effective from a policymaker's point of view if it's not cost effective. Nobody's going to take it up. So that's a crucial part of RCTs now, is to try and model the cost effectiveness. And it's the bit that everyone will pay attention to. So that, in a nutshell, was the RCT. What I really wanted to talk about was the process evaluation in BeST. Preaching to converted here, the classical RCTs are concerned with the outcome evaluation. They focus on internal causal relationships, and there's less focus on the generalisability, i.e. just because this worked here, is it likely that it's going to work in a different context? Context isn't necessarily taken into account. But why is context important? Well, our trial operates in Glasgow and London, and the intervention originates from New Orleans. So there are various contextual differences, and what we need to know is, what does somebody in Delhi or in Oslo or Buenos Aires need to know to be able to run the same programme, and are they going to end up with the same results? So in terms of different contexts, Scotland and England have two different legal systems. The legal systems are different in America again, or in New Orleans where the intervention came from. We have an NHS and a welfare state in the UK. They don't in the US. So arguably, children that we see in social services in the UK may well come from families with much more entrenched difficulties, because actually the NHS and the welfare state may have worked with those families at an earlier stage in the UK, whereas everybody in the US comes in at regardless of level of difficulty or tariff. Dual registered foster carers, these are foster carers that are in the US that are cleared to adopt children if those children can't return back to the care of their parents, which means that child goes into foster care, and if they can't return back home, they remain in that placement, whereas in the UK we don't have that. We have temporary foster care, which necessitates a further breakdown in placement to move that child to the next placement, whether that's adoptive care or back home to their parents. And in the UK, we had instability in the care system. I think an audit in 2010 in Glasgow showed that up to a third of children they were returned back home after a period in care, then came back into care, and you end up with this yo-yoing backwards and forwards, which is not good for children. So this is that diagram of normal RCT interventions. You get your interventions and you get your outcomes, but context sits above all of that. And what we're interested in is two of the aspects of context of the legal system and the social care foster care system. What process evaluation theory talks to us about is that context can influence the interventions and they can influence outcome measures. But outcome measures and interventions can also influence the context. So an example of that would be that in London, there's a 26-week timescale that children have to go through the legal process within 26 weeks, and a decision has to be made about whether they can return back to the care of their parents or whether they will go on to a permanent placement. That 26-week timescale doesn't exist in Scotland. So by necessity, if you're measuring how quickly a child goes to a permanent placement, the legal system already determines that they will go in within 26 weeks in London. So there's already an upper limit, whereas there is no upper limit in Scotland. In terms of the interventions, what we saw was that because NIM is a very involved process, there was negotiations with the judiciary that then meant that those children that were involved in NIM had a further 12 weeks, 38 weeks, I think, to be able to go through the legal process. So the legal system then had to adapt because of the interventions. There's two examples there of how the interventions can influence the context and how the context can influence outcomes. There's many, many more that we can see, and that's essentially how we work out what works for whom and in what context. So just because one of the interventions might not necessarily prove to be efficacious in one context, what we want to know is, well, why did that happen? Was that to do with the legal rules? Was that to do with the social policy context? If you had a different social policy context or a different set of legal rules, would the intervention be more successful in those environments? So that's soft theory. An example of how we use this in practice is, so we're looking at how long does it take a child to get to permanent placement. What we know is, this is fairly axiomatic for anyone who works in the field. Lack of permanent placement leads to poor outcomes. Placement instability leads to poor outcomes. And what we really want to know is, how long does it take children to get to a permanent placement? And what form does permanence take? Slight digression. In 2017, the Supreme Court in the UK appealed a permanence order that was issued in West Lothian. Permanence order is a kind of a legal order that allows children to remain in permanent foster care. They made assertions about what can and can't be considered evidence, and they made statements about the nature of parenting. So what they said was, and I'm going to rattle through this because of time, but essentially that facts either happened or they didn't happen. There's no room in law for facts might have happened. But that might have happened is the sphere in which social practitioners tend to operate. They tend to talk about concerns. The health visitor phones up a social worker and said, I'm concerned about child X, these are the reasons why. Social worker notes that down in the report, and then that goes to the courts, and these concerns sort of grow and grow. What the court said was, it's not enough just to be concerned. You have to evaluate the concerns, you have to solve them, and you have to evidence them. We have to talk about them in terms of proof. Facts are binary, they either happened or they didn't happen. What they also talked about in the Supreme Court is that society must be willing to tolerate very diverse standards of parenting, including the eccentric, the barely adequate, and the inconsistent. Children will have very different experiences of parenting and very unequal consequences. Some children will experience disadvantage and harm. This is the Supreme Court that has laid this down. Whilst others flourish in atmospheres of long security and emotional stability, it's not up to the state to spare children all the consequences of defective parenting. That's the point of this quote. This is case law now. So this is how social workers, lawyers in the field have to pay attention to this, and this is how they have to base their judgments. So we did some qualitative work to look at how does the legal system impact on children's outcomes. And EV, this judgment came out as a fairly strong theme. People were viewed in their opinions as to the importance of the EV judgment. So sheriffs, for example, acknowledged that the onus is on detailing the evidence for concerns, but they questioned whether or not the judgment itself changed practice. However, social workers, infant mental health staff, lawyers that work for the local authority were very, very definite in their view that EV had slowed down the process and it was causing significant drift. So this legal judgment had come in, and because of this legal judgment, practice had changed and it was leading to poorer outcomes for children. This was a widely held view amongst social workers. And I was in practice at the time, and I remember this coming out, roadshows and so on. There was a lot made of this particular judgment and a lot of predictions about how things were not going to be, how things were going to slow up and the outcomes for children were going to be a lot poorer. There's a couple of quotes here from infant mental health staff. I'll just give you the gist of it. Essentially saying that it's not easy to prove things like emotional harm. And what is adequate for one person might not necessarily be adequate for the next person. And so providing evidence in the way that EV says it should provide evidence is actually quite difficult. So social workers were of the view that this was going to take a lot longer and outcomes are going to be poorer for children. So our contention was, well then, can we test this? Just because they're telling us this, does this actually mean that this has happened? Took 198 children from our cohort, and I'll take you to the main gist of this. We did a Kaplan-Meier, a survival curve, and what we found was within 2.5 years, 30% of children were in permanent placements, and it plateaued, the curve plateaued at about 7.6 years with 56 kids in permanent placements and a sort of probability of about 0.61 of reaching permanent placement by that time. It's all very interesting. It's very sad if you think about what that actually means for children. But the purpose of this was to test what the social workers thought. What we found was that age at entry to care, how old the child was when they were received into care, made a difference to how quickly they would be in permanent placements. I.e., older children took longer to get the permanent placements, but not by much. What we then did was we separated 2 different time periods, 4 years pre the judgment and 4 years post the judgment, and we looked to see which proportion of children reached permanent placements within those times. And what we found was there wasn't any statistically significant difference between the two curves. Now, our sample sizes are pretty small, so we need to do further work to see whether these numbers bear fruit. But what was interesting for me was that social workers and everybody else in the field were so definite that this was a feature, this was going to be the case, that it took longer for children to get to permanent placements. But when you then, so that came from the qualitative analysis, but until you did the quants work, we couldn't then make comment on whether or not that was actually the case. So to conclude, what I would say is the process evaluation is really important in an RCT. It allows us to try and work out what works for whom and in what context. But you can't investigate such complex phenomena without mixed methods. You can't just speak to people, or you can't just look at the numbers. You have to do a combination of the both. We need to be able to drill down and look at breadth. The methodology has to be built on iteration to a degree. You have to be able to respond to emerging phenomena. And crucially, this does require working in partnership with your stakeholders. We wouldn't be able to do any of this stuff if it wasn't for the fact that local authorities that we're working with are on board, the health board are on board, and being able to access all this data. And that is essentially it. 50 minutes.
I think we'll take some questions in the room first, if anyone has any questions.
I'll shout out.
So, you said that age didn't have a very big effect, but that was per month, wasn't it? I mean, isn't that quite a large effect by the time you look at, you know, say the difference between a 1-year-old and a 6-year-old?
Yes, I suppose that was see. Yeah, and it was it by month or was it by day? It was by day, so the effect would be even larger.
I think it says per month.
On months, so you know, you're right, it is by month. Yeah, but I suppose the numbers are still pretty low, or still pretty close to, so the beta is still pretty close to 1.
Okay, but if you take 5 years, that's about 60 months.
Mhm.
So that would be like minus 0.6. So yeah, exponentially that's about like a 2.5 to 3-fold difference. So
It might be, you know, that's something that we haven't considered, so I will
I
take
just
that.
wondering if it might be better at different scale. Because it depends on the age ranges of kids that you're dealing with as well.
Yeah, so they're all 0 to 5, and there's but there is a wide range within that of when they come in. But yes, you're absolutely right. That's why we do these things. Excellent. I will take that back.
Yeah, you go first. Yeah,
I was just going to say, so your framing of what works for whom in what context and why is kind of a realist evaluation framing. Are you trying to get at underlying mechanisms for why certain outcomes are different in certain contexts?
Yeah, so what we do, what I didn't go into here, is that we, there's a number of different frameworks for doing process evaluations, and realist evaluation is one of them. So we have a theory of change that we've developed, and we had developed right at the very start. And then what we do is we work out over the course of the many years that the trial has been going on, how contexts, we try and define context and then look to see how context, mechanisms and outcomes come together to, so that might be something like, in a legal context like Scotland, where you don't have a judge overseeing proceedings, it's much easier, our participants in our focus groups think it's much easier for a psychologist to get their point across in these tribunals than it is for a social worker to get the point across, which means that these tribunals will give the result to a psychologist faster than a social worker. So by virtue of your profession or which service you go to, the legal system might operate in a much faster way for one group than the other. It's got nothing to do with the intervention, it's just to do with the perceived expertise of the person delivering it. So there's a mechanism there about how quickly you get through the legal system, which might lead to quicker placement in a permanent placement, so there's your outcome. So the legal system is the context, the mechanisms is how the tribunal deals with you, and the outcome would be, well, how quickly does he get through that placement? What we then do is you take all of these context, mechanism, outcome sort of configurations, and then we plug them back into our theory of change to see if we can have a much more rich and sort of iterative theory of change that talks about, well, in this context, this would be better, in this context, this is how this works. Does that make sense? I hope I'm explaining that. Sort of, it's difficult to explain without a diagram, but it certainly makes sense to me.
In the interest of time and fairness, I think I'll just ping it online, see if there was any questions, Hamish.
Not as far as I'm aware. Don't see anyone
Okay.
with a hand up.
Just because we were running 2 minutes late starting, I'll just
all I wanted to say was that was an excellent presentation. I really enjoyed it. Thank you so much, because I think you've got a lot to get into in 15 minutes, and I think you did a really great job. And obviously I'm biased because I work in the economics, so it was nice to see you flag the economics. But also it was just a comment really, just to say that I agree with you entirely. This is a complex public health intervention evaluation. It's incredibly challenging across the whole team. So, and I think you did a really good job of articulating it, and I agree with you entirely about the importance of mixed methods for this type of research.
Okay, thank you.
I'm looking forward to seeing the final results.
So are we.
Great, so I think we'll now move on to David, if that's okay. I'll stop sharing that. No, we've just stopped sharing for now.
No, I'm just trying to get the stop view so we can see what we're coming across on the camera like, but it doesn't matter.
Oh, okay, yeah.
Yeah.
I don't know if they can actually see what's happening in the room. We've done some testing to try to see if we can see us. We've tried to make camera as much as possible. If you did want our online audience to see us, I think if you stand here, they would see you, but.
I'm quite relaxed.
Cool. Great. So,
so-
share the screen. That good, Hamish? Great. Well, you have 15 minutes to present and then a few minutes for questions.
Super, thank you. Welcome back to face-to-face meetings, and hi to the online audience as well. I'm David, I'm a GP and senior clinical lecturer within the general practice and primary care group, and I'm going to be talking about some emerging lessons from a remotely delivered RCT. So just briefly, became interested in the issue of long COVID, partly through clinical work and then involvement in the first UK-based qualitative study amongst patients with long COVID, and then I've been involved in the COVID in Scotland study, which Jill will speak about shortly, and then this NIHR-funded ReDIRECT trial. I've also been involved in the NICE sign RCTB guideline for management of long-term effects of COVID. So what is long COVID? This is the sign definitions. So you have the acute infection up to 4 weeks, ongoing symptomatic is 4 to 12, and then long COVID, sometimes known as post-COVID-19 syndrome, is any persistent symptoms beyond 12 weeks. What are those symptoms? Really a wide range of potential symptoms affecting multiple different body systems, from respiratory, cardiovascular, neurological, and beyond. Who gets long COVID? Well, this is still relatively novel conditions in the last 2 years or so. So we have some data from longitudinal studies, some data from electronic health records, but the evidence that we have suggests that prevalence is slightly higher in women compared to men, slightly higher in older age groups, in those with pre-existing health conditions, in those that have been hospitalized with initial COVID infection, and slightly higher amongst those with raised BMI as well. So there is an association between both severity of COVID infection and obesity, but also long COVID and obesity. So this is the ReDIRECT team. The call for research to look at long COVID in non-hospitalized individuals came out in early 2021. And our idea was to repurpose the DIRECT study. So this was a weight management intervention aiming to put type 2 diabetes into remission through weight loss for a long COVID population. The novel aspect of this trial was that we used personalized outcome measures. So given the wide range of long COVID symptoms, we used validated outcome measures for fatigue, pain, breathlessness, anxiety, depression, and also on other. So participants would nominate the long COVID symptom which was most impactful for them, or which they most would like to see improve through the course of the trial. So I've kind of hinted at this already. Why weight management? Well, at the time, and indeed now, there are no established treatments for people with long COVID. There is an association. There's several different hypothesized mechanisms underpinning long COVID, one of which is persistent inflammation. And we know from other patient groups that weight management can have an anti-inflammatory effect. Weight management programs in adults with overweight and obesity can also reduce some symptoms such as fatigue, breathlessness, pain, which are also common with long COVID. But we don't know whether intentional weight loss would help people with long COVID and any of their long COVID symptoms. So this is the sort of timescales. Call in March, expression of interest May, deadline the week later, and then within 6 weeks award and start 4 weeks later. Incredibly tight timescales, which brought its own challenges. We aimed initially to recruit 200 people, so 100 in the intervention arm and then 100 in a delayed entry control arm. We managed to get some additional funding to extend that to 240 because recruitment was going so well. I mentioned the personalised long COVID outcome measures, which were recorded at 0, 3 and 6 months, and follow up to 12 months. And we have a process evaluation and health economic evaluation going alongside that. So a kind of brief snapshot of where we are today. So we finished recruitment. We have randomised 235. So majority of the intervention arm have finished their 6 months, but you can just about make out that there's a range of different stages of completion of the assessments, and that's one of the challenges I want to talk about. But I'll start with the strengths. So we think that the strengths of this are in relation to the intervention itself. The focus on diet is something which definitely got the support of our long COVID PPI group. There were many people with long COVID who were already trying various different diets to try and improve their symptoms. There was no requirement for exercise, and if you're familiar with any of the controversies around long COVID and exercise, you recognise that that was something that many people do not want to go near. The aspect of it being fully remote, so the participants do not need to leave their homes. There's no kind of additional burden of visiting clinics to be part of the trial. This was some feedback in terms of the benefit of simplification of meal planning and decision making that could be quite stressful for some people with long COVID. That was removed by having a kind of 12-week total diet replacement intervention. There was a track record, so we knew from previous research at ReDIRECT and other studies that this was effective and safe, effective in weight loss, not necessarily in terms of long COVID symptoms. There was flexibility built in to the intervention, so if people did not want or didn't suit the total diet replacement, there were other meal replacement options, low carb options as well. And there was very strong peer support built into the intervention alongside the strong dietitian support. I mentioned the personalised primary outcome, and that the whole process involved people with long COVID from the outset. So I think this was, it's a requirement of NIHR funding, but it's something that we managed to do, I think, reasonably effectively. So in terms of challenges, well, long COVID itself presents a challenge in terms of the fatigue that people experience, the brain fog, the pain, the breathlessness. All these things make it very difficult to fill in a questionnaire, for example, or to necessarily answer phone calls at different times. So I think the kind of workload required amongst our research team has been greater than for similar studies in different patient groups. The relapsing and fluctuating nature of symptoms, I think, make it hard to interpret changes. What is, if you're feeling better, is that because of the intervention, or is it just part of the nature of the illness? And likewise, if you're feeling worse. There are mentioned lots of other diets that people are trying anyway, so low histamine diets, anti-inflammatory diets, and a range of different supplements which can potentially confuse the issue. And long COVID itself has GI symptoms for many people. So again, hard to disentangle whether changes in eating patterns may be causing GI symptoms, or whether, again, that's part of the condition itself. And the remote nature of the study means that we're relying on self-reports, self-reported. We send out scales and BP monitors. We're relying on self-reports for those measures. Further challenges in terms of the inclusion criteria. On the feedback of our PPI group, we made it pretty inclusive, such that it's basically self-reported long COVID. So we didn't require a confirmed positive COVID test in order to be included and to have to take part in the study. Primary care recruitment was a real challenge. Most of our recruitment came from either from existing groups, networks of people with long COVID online, or through long COVID clinics, more than through primary care. And I think this was due to the very low recording and coding of long COVID within GP records. We did come across some social media criticism, but I think having strong PPI input helped us navigate that. So one of the critiques was, why are you looking at weight loss? Lots of people with long COVID are not overweight. Lots of people were previously very, very fit and had long COVID, but I think that was kind of missing the point of what we were trying to do. So hopefully we managed to do that. We tried really hard to get a diverse sample, a representative sample of participants, both in terms of ethnicity, in terms of socioeconomic status, geographic spread, and male and female as well. And I think we've done reasonably well with that, particularly in relation to across the 4 nations and socioeconomic spread of participants, but we do have a predominantly white, well-educated female population. And yeah, I guess just to mention the challenge of the timescales again, and hopefully that's me.
Okay. I think in the interest of fairness, Hamish, we should start with any online questions this time.
Any questions from the Zoom-based audience? None in the chat. So unless you have a question, maybe go to the room.
Okay, we'll open it up to the room. Got one.
Thanks for the great talk. It was very interesting. So my question is that, for example, in the cardiovascular clinical trial, the participants are always given a drug for a certain dosage. But here, for the participant on the diet, how could they know how much they will eat? Or do you have a standard for different people have different total amount of calories or something?
Yeah, it's a good question. So the main intervention.
Please, can you repeat the question, David?
So I think the question is about standardization of dose, broadly speaking. So how do you know that all the participants in the intervention are getting the same intervention, if you like? And I think that's a good question. So as I say, the main intervention is this total diet replacement, which is a choice of porridges, shakes, and soups, but it's a defined 800 calorie. So that is fairly consistent. I suppose we don't know always exactly how that's taken, but the dietitians are pretty good at monitoring that. So we had to have a question about, for the process evaluation, we have a question about the fidelity of the intervention. Yeah, I think, sorry. Yeah.
One question here.
Just as a couple of things. So I was just interested in how good the retention is within the trial, given that something like a very low calorie diet is something that's quite a challenge, particularly for people who are obese and maybe had disordered eating in the past. And just wondered how good your retention was. And my other question was about long-term follow-up. Is there a plan to follow this up, given that potentially after the variable calorie diet, things might rebound? So it's fine.
Yeah, really good
Sorry, could you
questions.
repeat the question briefly again? Couldn't quite.
Yeah, I can repeat them. So the first question was about retention, so levels of retention in the study, and the second was about follow-up. So in terms of retention, I can't give you the exact percentage at the moment, but it's pretty good, I would say. Most of the reasons for people withdrawing are not related to the intervention itself, it's other life circumstances. I think having the flexibility of moving, not just the total diet replacement, that there are other options for those who find it difficult. So I think our retention is reasonable. Follow-up, definitely, yes, I think there would be a plan to follow up longer term, similarly to how they've done with Direct.
Okay, I think we've got time just for one more question.
Thanks, David. Brilliant talk. Do you have any sense of participation rate? Because this was almost like a self-selected group from people who were engaged with the long COVID community. Do you know how many people approached and then decided not to take part?
Yeah, we probably have a sense of that. We had people that had, so this was a question about how many people changed their mind having initially expressed an interest, broadly. So we've captured notifications of interest. And I'd say over half of the notifications of interest became enrolled in the study.
And then you had a breadth of outcomes, including one was the patient's choice depending on the symptoms which are bothering them the most. Did you have one primary outcome? I may have missed them.
No, so the primary outcome is a choice of 5.
Okay.
And that is nominated by each participant.
Right.
Yeah. And that's Alex McConaughey is going to do the clever statistics to work out how that's going to work.
Great, thank you very much. Okay, so we'll stop sharing our screen in the room, Hamish, and then whenever Jill's ready, if she can share her screen, and hopefully that will work for us.
Hamish is doing the admin for me, so because I'm partly because I'm a VIP and partly because my IT is not working. So I'm going to tell you about the long COVID in Scotland study, Long-CISS. It's led by University of Glasgow, but we partner with Public Health Scotland and the Universities of Aberdeen and Edinburgh. So next slide, please. So people are recruited to this study through the contact management system. It's a system the NHS set up to notify people of their test results. An invitation is sent to them automatically by the same company that sends out the NHS notifications. They have the option to opt in with e-consent or withdrawal at any time. Next slide. I don't think these are in the right order. Okay, so one of the big problems we've had with this study has been getting approvals for it. NHS ethics were fantastic. We had real problems getting approval from PBPP, and we needed to fill in not only a rapid DPIA, but we were then asked to fill in a full DPIA, along with an SSP and a PERC, some of which I'd never heard of before. Next slide, please. So the problem around consent was the fact that we needed to know whether people were test positive or test negative before we actually contacted them to obtain their consent. So we needed data in order to then obtain consent. If you actually look at data protection legislation, consent is not a requirement. All that's required is that what you're doing is lawful, that you're transparent, you're open about what you want to do, and that you're using the data for a reason that is reasonable to people whose data it is, that is compatible with why it was collected. Consent is an ideal way of showing those, but it's not actually a requirement. So what we did in our study, next slide, please. First of all, we increased awareness of the study, the transparent bit. We had a Scottish Government launch, we had a press release, lots of media coverage, made sure we had a big presence on the web with a website and FAQs. Next slide, please. And also what we did was then show, actually applying kind of a research approach, that what we did was not unreasonable in the eyes of both the general public and the participants for the study. So we tracked the contacts we had from the general public when we launched the study. 156 people contacted. The vast majority of those were very positive contacts from people just wanting to volunteer and take part. There were only 2 negative contacts. One was complaining about the government, nothing to do with the study, and one just wanted clarification around data protection, but was otherwise happy. And then after we sent out the first batch of invitations to 250,000 people, only 97 people emailed us. And again, most of those were technical or supportive or miscellaneous queries, nothing negative. Again, there were only 2 out of the 97 that had any sort of negative overtones. One was a complaint against the government, again, nothing to do with the study. And one person wanted to know about FOI process, which we told them about, but they didn't actually submit an FOI. And at that point in the study, we only had 0.002% withdrawal from the study. So it was accepted by the people we approached and the people that took part. Next slide, please. So the strengths of our study: we did a large-scale study, unselected, general population based. We had objective measurements of exposure to COVID. We had a general population comparison group, and we included everybody who got COVID, both asymptomatic and symptomatic individuals. And we followed follow-up through several means: self-reported information through questionnaires, record linkage to routine data, and qualitative interviews. We were able to get serial outcome measurements in the same individuals, and we're able to look at a lot of different aspects, some of which we haven't analysed yet: variance, vaccination, socio-demographic factors, etc. So next slide, please. So far, we have sent out 5 waves of invitations. Over around 2.4 million invitations have been sent. 700,000 of those are to people who are infected. Infected being that they had an actual PCR positive test result. And then 1.7 million to people never infected, i.e. they've had a test, but it was negative. They've never had a positive test, and they've confirmed that they never had a positive test that wasn't on our system. So we've had 250,000 questionnaires completed so far. That's a 10% recruitment rate, and that equates to almost 200,000 unique participants. And the vast majority of those have also consented to linkage. Obviously, we've lost some negatives over time because they become positives and then have to change arm. So we originally started out with a 1-to-3 matched comparison group in the general population, but we're now down to 40% infected, 60% never infected. And the penultimate wave of invitations has just been sent to another 1 million people. Next slide, please. So the good news is that people get asymptomatic infection. There's no evidence that in the longer term they have any problems with any adverse outcomes, so you can be reassured by that. They recover, they don't have symptoms, they don't have impact on their lives more widely. Next slide. So the results here on in relate to people who had symptomatic infections, and they account for 95% of the test positive individuals. So at the time of infection, most people have more than 1 symptom, and in fact 82% have more than 3 symptoms. Most people have symptoms for at least a week, and 1/3 of them have symptoms for more than 4 weeks. And the most common symptoms, you've already heard from David: fatigue, taste and smell, particularly in the original variants, are affected: headache, muscle ache and cough. Next slide. So if you look at what symptoms people have at follow-up, so this is 6, 12 and 18 months follow-up, we looked at 26 different symptoms. Now this graph shows why it's so important to have a comparison group, because the blue bars are the prevalence of these symptoms in people who are infected. But as you can see from the orange bars, there are a lot of people in the general population that have a lot of these symptoms, because most of them are very general symptoms. So apart from taste and smell, they're actually very common. But when we put it into the models and compared the symptomatic infected people with the uninfected people, we found that 24 of the 26 symptoms were in fact more common in people who'd been infected with COVID. The only exceptions being abdominal pain and sickness and vomiting. Next slide, please. And these symptoms had wider impacts on people's activities of daily living. So again, the blue bars there are people with COVID, and high prevalence rates of impact on relationships, hobbies, walking, work, etc. But again, these things do occur in the general population. But when we put it into the models, all but washing and dressing, all of the other activities of daily living were more common among people who'd previously had COVID infections. And in fact, their quality of life in terms of EQ5D scores were also lower. Next slide, please. So self-reported recovery status. So this is on the last follow-up for the individuals that participated. They were asked to self-classify as to whether they feel fully recovered, partially recovered, or not recovered. So only 52% of them thought that they were fully recovered, and quite a significant proportion were only partially recovered, and 6% not at all. These are actually quite high figures for not being fully recovered compared to some long COVID studies. And again, we put it into model to look at the factors associated with recovery. Recovery was less likely if you're older, more likely in men, more likely in non-white groups, which might seem counterintuitive, but it might be that the prognosis among non-white groups is worse initially, and you have to survive at least 6 months and be well enough to take part in the study. So it might, be an implicit bias in the study design. Affluent people were more likely to recover. People with multimorbidity, less likely to recover. Next slide, please. So the bit that we're looking at now, so we know as a sort of cross-sectional look how people are doing at follow-up. What we're interested in now is looking at trajectories of the disease. So how people's status changes over time. So we've now got enough people who have filled in questionnaires at both 6 and 12 months or 6 and 18 months to look at this. So overall, 75% of people, whatever status they were at 6 months, is maintained at 12 months. That falls slightly by 18 months. There are 12% of people, though, whose status, self-reported status, deteriorates between 6 and 12 months, and that goes up to 15% by 18 months. And again, there are 13% of people who say that their recovery status improves over time, and that goes up to 15% by 18 months. So there is some transition in the status, as has already been mentioned. Next slide, please. So the factors associated with change in recovery status, we've shown so far that more affluent people, this is the 70 quintile, is associated with the highest levels of affluence. These people are more likely to improve and less likely to deteriorate over time. Men are less likely to deteriorate. Older people are less likely. Oh. Sorry, my phone's ringing. Sorry about that. Right, what are we up to? Older people are fairly static. Wherever they are in 6 months, they tend to stay there. They're less likely to improve and less likely to deteriorate. And people with a history of depression prior to getting COVID are less likely to improve and more likely to deteriorate. And we're looking at that group in particular in more detail to see whether it's related to the specific drugs that they were on, etc. Next slide, please. So this bit's very much work in progress. So this slide just shows you some very crude figures on changes in symptoms among the group that have had symptomatic infections, to say how it's changed between 6 and 12 months. So you can see that the symptoms that appear to improve are confusion or poor concentration, altered smell, and altered taste, where there does appear to be a reduction, a very slight reduction in prevalence between 6 and 12 months. Perhaps counterintuitively, there is a worsening in the prevalence of people who have dry cough and productive cough. We have to be absolutely sure this is a real finding. So what we're doing now, obviously, is looking again at this comparison group, because they're 6 months older, they could simply have developed respiratory problems and so on, irrespective of COVID. So we need to see whether it's a real change or not. But this is work that is ongoing. And I think that's the end of the results. So next slide, please. So just to say, first of all, thank you very much to everybody else involved in this study. There are a number of other collaborators in Glasgow, and in particular, I want to thank Claire, who's done a huge amount of heavy lifting on this project. So thank you, Claire, and also our collaborators further afield. It was funded by Chief Scientist Office, but we also get additional funding from public when we needed it. So thank you very much to them. And I've just realized what the problem is. I think we must have skipped the second slide, which actually had all the methods, but hopefully you got enough of it. Yes, that's the one that we skipped over, but never mind. Hopefully you gleaned that anyway. So that's it.
Apologies, that might have been the way in which I shared it. I'm not sure.
That's fine. You did a sterling job.
Okay.
We take online questions first.
Yeah, so there's a question here from Ruchika. She says, thanks, Jill. How is recovery measured on all the symptoms or person-centered changes?
So recovery is entirely self-classified. We just ask the person to say, have you fully recovered? Are you partially recovered, not recovered? So it's very subjective. And obviously we don't have a comparison group for recovery in people who aren't infected because they've got nothing to recover from. That's why we need to basically be able to triangulate. So we also get specific symptoms, again, self-reported, but we've also got, and I haven't presented the data here, linkage to hospital admission, linkage to drug prescriptions, linkage to deaths. So basically looking for consistency in results across a mixture of objective and subjective measurements.
There's an online question from Beverly. You have your hand raised.
Thank you very much indeed. Can you hear me? I'm trying to activate my video, but with a total lack of success. Can you hear me okay?
Yes.
Good. I was very impressed by the graph showing the frequency of symptoms in people who were symptomatic and asymptomatic. And there's a very similar graph that was produced by Simon Wesley and his team at King's, looking at Gulf War syndrome and people who served in the armed forces at the same time but weren't deployed to the Gulf. And again, that largely shows that the symptoms that the people were complaining of were pretty much the same as the symptoms that people in the non-exposed population were complaining of, but at a higher frequency, pretty much across the board. And I wonder if there's some sort of message to be sucked out of this. Are we dealing with something which is somehow similar, and indeed could we look at similar studies in other vague conditions such as CFS, ME and chronic Lyme?
So firstly, just to correct the first bit, it's not asymptomatic. They're people who are uninfected, rather that it excluded the
well, that's even closer then, because Gulf War study was Gulf War syndrome against people who had served at the same time but didn't go to the Gulf.
So you're absolutely right. I mean, the only two exceptions, and again, it was with earlier variants, not the current variant, were altered sense of smell and taste, where they're very uncommon in the general population and were common post-COVID. But other than that, there were symptoms that you find generally in the population. They did occur more commonly, and when we adjusted for confounders, they still occurred more following COVID. But it was not that they had some bizarre symptoms. They had a whole range of fairly common symptoms, but just more frequently.
Yeah, I just feel that there is a link here with other, what at the time of the Gulf War syndrome investigations we were calling medically unexplained symptoms, where it was very much the sort of things that were occurring in the general population, but just much more of it.
Yeah.
And interestingly, when the Gulf War studies were followed up some years later, the unexposed population was showing a higher frequency of symptoms as well, suggesting that there was something going on in the wider population that was increasing the risk of tiredness, fatigue, skin rashes, lack of concentration, and so on.
Yeah, I mean, I think it's very, very important we've got a comparison group, because I mean, just saying that you're breathless after COVID, you know, you have to show that it was associated with the COVID. And in answer to John's question, did we rate the severity? No, we just asked people what symptoms they had in the last week. And we also knew what symptoms, what medical problems they had before COVID, but no, just they were breathless, yes or no, in the last week.
We have two more online questions, one from Ataya. Apologies if that's poor pronunciation. Naive question. Thanks for the talk. Women in general are more immune, given that average age of male is less. It is a bit remarkable that men could recover better. If not sure if that's that question. I don't know if you can explain that anymore, Ataya.
Again, and it's a bit like the ethnicity thing. So we have people who must have at least survived 6 months and then take part in the study. So I'm a little bit worried about how we interpret the ethnicity results, and it may apply to the gender results as well. That to say, you know, how people do at 6 months, you might have had a survival bias or recruitment bias prior to that time. So if you have worse early outcomes, then you may end up having better long-term outcomes because your recruitment starts at 6 months. So I think we do have to be a little bit intelligent in terms of how we interpret the results.
And we've got Laia with your hand raised, sorry.
Thanks, Jill. That was really interesting. This may have been on your methodology slide, but you showed that there was worse outcomes for workability. And I was just wondering, did you collect any information on occupation or types of jobs or tasks that people did?
No, unfortunately, this was an app-based thing, and we had to be very, very careful about, how much people will tolerate on a small screen and for how long. So we were able to ask them, does it impact on your work? Does it impact on education and so on? But that's it, yes, no.
Great,
so,
thanks.
Yeah, we were stuck with the technology, I'm afraid.
Thanks.
There's a question from the Social Science Public Health Unit.
Hi, it's Ruth Dundas here. Thanks, Jill. The symptoms and the other outcomes you were looking at were self-reported. Have you got plans to follow them up and look at service use, either hospitalisations or GP or various other services?
Yeah, we've got SMR2 linkage, we've got deaths, and we've got PIS linkage. The last time we looked at the hospitalisation, it wasn't terribly exciting because we weren't powered then, but we're able to repeat it now. That was after the first couple of waves. So the intention is now we've got 5 waves and bigger numbers. We'll go back and have a look at that.
Can I just have a clarification? You said SMR2, did you mean SMR1, the hospitalisations?
I did. Thank God you were awake. I tell you, my coffee cup's up here. Yes, I could say looking forward to SMR2. No. It's definitely SMR2.
I'd quite like to see the SMR2 ones for the...
No, I think Ruth Reynolds had...
No wonder you had trouble with the PBPP application.
We didn't know how to do numbers. I know. No, Ruth Reynolds tied up all of the SMR2 COVID studies, so I don't think we were ever getting that. No, it's SMR1, you're right.
There's more. Yep, go for it, Rosie.
We've got a few questions in the room, so we've got 2 minutes. So I'll take a question from you first.
Yeah, great, thank you. That was really interesting. Apologies if I missed this, but I was quite interested in the change of recovery status, particularly those that went from full to full recovery after 12 months, and then at 18 months it went to sort of full to partial. Were you able to find out if any of that was because of reinfections, so second or third infections? If someone had a second COVID infection, would they reset back to sort of day one, or were you sort of collecting data on if they had a subsequent COVID infection?
So this is on our long list. So as I said, this is an ongoing saga, the study. So one of the things we've got penciled in is reinfection. So at the moment, what we have approval to get is your first eligible test. So your first positive test or your first negative test if you're always negative. So one of the amendments that poor old Claire's hopefully going to put in on top of all the work she's already done is to ask for the data on reinfections so that we can look at reinfections. The one thing we need, I'll need a lot of coffee for this, is to get my head around how to analyze reinfections, bearing in mind that follow-up time for questionnaires was based on time of first test. Might not be right for the reinfection test. So I think that's a triple espresso kind of meeting that we need to have at some point to figure it out, but we are planning to look at it.
Okay, thank you.
I think in the interest of time, and it's 1 o'clock, I'll just, if you could follow up with Jill. But I think this has been a very successful first hybrid meeting. Thank you all for attending. And I think there's a similar session every month now for the academic year. So any comments from online, or is everyone happy?
Yeah, there was a bit of an issue if people could have the microphone close, the speakers could have the microphone close. I don't know if they could have a wearable microphone for future ones. But yeah, otherwise I think it went well. Thank you, all the speakers.
Any feedback, feel free to email Odd or any of us. And thank you very much for your attendance. And to the speakers, thank you.
Sorry about your slides, Jill. I don't know what I did. I was trying to manage the chat, trying to do
no problem. I just suddenly thought maybe I put them all in the wrong order. So I was quite relieved it was just one that was missing.
Okay, thank you very much. Bye.